What's the theory behind it? Like, how does it work?
Well, we don't entirely know.
Yeah, I know, right? But it
I mean,
works.
like many drugs, we know the mechanisms and we know these outcomes, but we don't know if this exact mechanism leads to this exact outcome. So there are some theories, and one of them is that it creates this opportunity for what's the word I'm looking for? Very profound neuroplasticity.
Welcome, everybody. My name is Dan Sundahl. This is the Dan Sundahl podcast, where we discuss mental health, well-being, and creativity, maybe some artwork stuff as well, and what that means to mental health and well-being. And today I'm joined with my good friend, Dr. Alexandra Jabber. Alex, how are you?
Good. Thanks. How are you?
Great. I'm happy that you're on my podcast. This is a new venture for me. Not that I have enough stuff on the go already, but I think this is really an important way to kind of get the message out there for people that that want to improve their lives and find ways for overall better mental well-being. So why don't, for those of our viewers that aren't familiar with you and what you do and who you are, give us a little rundown of what you're all about and who you are.
My least favorite question, but I will
You
try
knew
and
it was
make
coming.
it. I knew it was coming. All right. So I am a licensed paramedic. I medically retired with quite a bit of education under my belt as an educator. So I was able to, very grateful that when I had to exit my time on the ambulance, I got to just focus my work in education. So I, consider myself EMS adjacent. So I'm an EMS educator.
I use that from now on. I love that. And I give you credit every time.
Well, thank you. It's actually going to be part of my opening when I speak at your conference, is, talking about what those EMS adjacent kind of things look like. And it comes from my experience in doing it. I would say that being able to teach really saved my life, because I was very wrapped up in the identity of being a paramedic. And when overnight it was off the table, potentially forever, which ended up being the case for my ability to physically be on the ambulance, it gave me a sense of renewed purpose in a different way. And also, an opportunity to really uncouple that identification with being a paramedic. But all that aside, that injury led me to continuing my own personal education, higher education. And I didn't stop with a master's, and I decided to go get my PhD as well. So that's where the doctor comes from.
You can't just skim it over that quickly. It's like, oh, yeah, I injured myself and then I went to school and got a PhD. And yeah, I'm not going to let you get away with that. Back injury, right?
It was back injury. So I guess to sum it up, I am a former paramedic, still licensed, still serving EMS, but as a continuing education provider. So I actually create custom curriculum and CEs on whatever I find interesting, but usually comes back to some sort of psychological health for the first responder.
Yeah, and we're going to talk about that. Some of the education you have, some of the CE courses that you have, very unique courses that some cases I don't think anyone else is doing, which I think is really important. And they're good courses, but they're also very relevant courses. They're very like real world useful. I'm not going to say education isn't important, because all education is great, but I think everyone would agree that some mandatory courses that we take are like, what?
Less than favorable. There is a
That's a good way of saying it.
There is a spectrum of quality, and I consider myself more like a boutique or a small batch creator, like farm to table type experience. You're not going to go on there and find all the CEs that you need to renew, which there are plenty of great organizations. I partner with many of them that can offer that. I'm more like, you kind of want to dive into, you want to hyperfixate on something really very unique, and you'll find it at my place.
So your company is Emergency Resilience, and I'll put the link underneath if anyone wants to get in touch with you, so they can find out exactly what CE courses and online courses that you have available to them for themselves or their service, and some really good, interesting ones that we're going to get into here a little bit. You have a PhD in depth psychology. What is that like? If this is normal psychology, and like is depth psychology like even is it deep psychology?
Honestly,
What is depth psychology? What does that mean?
So depth psychology is everything you don't see. So you might see somebody on the surface behaving in a avoidant, confrontational, reactive, or like a certain way. And you might be like, oh man, like that little interaction really set them off. But it actually has nothing to do with that interaction. It has everything to do with the stuff that's below the surface. What's operating in the subconscious? What programs are downloaded in our subconscious that are running the show in our conscious state? A lot of us, and that's not to excuse us of our influence that we have. We absolutely do. But a lot of times when we're butting up against a pattern or a behavior that we just can't seem to break, it's probably somewhere in the subconscious that we need to rewire it. So that is, in a sense, pretty much like your Jungian, Freudian type stuff is your depth psychology.
One of my professors would call that the juicy stuff. As a clinical counseling therapist myself, when we get into those things and we start getting to like child regression stuff and all this is like deeper stuff, then he would always say, yeah, that's the juicy stuff. That's where the good stuff is, right? That's where
so juicy psychology is what I have my degree in.
So yeah, basically you're a doctor of juicy psychology.
Dr. Juicy.
Yeah. Dr. Right now, on that topic of depth psychology and kind of really getting into the meat and potatoes of behavior and reactions and emotions, you do a lot with psychedelic therapy as well. So how does that tie in? What's the connection with that in depth psychology?
So my specialty specifically is ketamine. I did my PhD dissertation on ketamine therapy for first responders. Specifically, I did mine on firefighters with PTSD because I wanted to just run first responders through ketamine therapy. And my school was like, no, you can't do that. They're like, we don't have the insurance for that and we're not going to let you do it. And so I instead took the approach of speaking to union presidents throughout the state of California. And I was able to get a pretty good in and just talk to them openly about their perspectives of ketamine, their, thoughts and opinions of stuff. And we were able to come up with a pretty good piece of work. But my ambitions to run a handful of paramedics and EMTs through ketamine therapy got squashed pretty quickly. So, but I take an interest in all psychedelic therapy, but as a disclaimer, I always make sure that people understand that as openly as we're talking about things like ayahuasca, psilocybin, MDMA, LSD, all of those treatment modalities, as therapeutic as they appear to be, arguably are based on what the research has been telling us for decades. I don't speak about those because they are still very illegal for most of my audience, most of our audience. I know actually Canada has a lot more accessibility points for some of these things.
We do whatever we want up here.
So cool.
Whatever. Yeah, I have like a whole cupboard upstairs of LSD and ayahuasca, and I offer it when I make tea for people. So that's like you get it at 7-Eleven up here. Yeah. No, it's not like that, but I know what you're saying.
But it is more, you do have more access points to it in a controlled, safe, legal, medically controlled environment. Ketamine is the one that we have access to in these medically controlled and legal environments throughout the United States. And ketamine technically isn't a psychedelic, but it behaves like one. And in many ways, the most unique part about it, and the reason why I'm such a fan, is it acts as a tool to rewire our subconscious mind.
Great. So let's get into that. A lot of people talk about psychedelic therapy and they're like, oh, it's great. And not a lot of people really know, what is it? Does it mean if I'm working on the ambulance and I'm having a bad day, I had a small colic and just, sniff some of the ketamine I have no, right? You can't do that. So what's the theory behind it? Like, how does it work?
Well, we don't entirely know.
Yeah, I know, right? But
I mean, like many drugs, we know the mechanisms and we know these outcomes, but we don't know if this exact mechanism leads to this exact outcome. So there are some theories. And one of them is that it creates this opportunity for, what's the word I'm looking for? Very profound neuroplasticity. So neuroplasticity, you know that word, right? I'm sure. Neuroplasticity is this ability to rewire and heal the synapses in our brain. So it's not just the broken synapses, it's creating new pathways around them, it's repairing the damaged ones. And why they become damaged are a number of reasons. It's not just trauma, but trauma is one of them. And so through a series of mechanisms, you get this kind of fresh slate to work with. And it doesn't happen overnight, and it doesn't happen with just one treatment, but that is at the core of its value. And so the way I explain it is like, imagine, you remember Play-Doh. You get this like colorful clay, right? Play-Doh.
Okay, I wasn't sure if you're talking about the
Play-Doh
philosopher.
not philosopher.
No, I never met the guy,
Play-Doh
but I do
as
know
in-
of him. But I am
as in
very
Fisher
familiar with the
Price.
Play-Doh as a kid. Yeah.
Yeah. Imagine taking out this ball of Play-Doh that's been left out in the sun, dried out, not covered, not kept, and you try and mold something new with that. What's it going to be like? It's going to be impossible, right? Now imagine someone gave you a fresh batch of Play-Doh. It's going to be malleable. It's going to be moldable. You can make it do what you want. You can influence it to a degree. It's still going to be Play-Doh at the end of the day, right? You're still going to be you, but what kind of influence can you now impose on it with intention? So it's like taking your mindset, your mentality, your mantras, your manifestations, your prayers, your internal beliefs, and giving it little, like, for lack of a better term, steroids. Like, you put it on, like, you get this boost of this advantage to doing those things. And so it acts as a tool. That's it. You have to do the work. So, for example, if I'm going into a ketamine therapy session with this mentality that I'm a horrible person, that I messed this up, that up, I'm not worthy of love, I'm not, I have imposter syndrome, someone's going to find out about me, I don't have the confidence for this, I messed up on that one thing, that moral injury that just sticks with me. If my goal is to rewrite that narrative I have with myself, then during the ketamine session, and especially in the 3 days afterwards, I am not going to permit myself to reinforce those negative self-limiting beliefs. Okay. I am going to rewire. I'm literally, even if I have to lie to myself to a degree, I'm going to state the things I want to replace those patterns with. I'm going to do the things that are going to replace those things. So someone said, can I smoke my cigarettes after, ketamine therapy? It's like, do you want to stop smoking? Well, yeah, then no. Yeah. Unless you want to reinforce that habit, then maybe tell yourself, I'll give myself 3 days without it. If they can, right? Obviously there's withdrawals and stuff, but you want to plant the seeds for the behaviors, thoughts, patterns, beliefs that you want to carry on moving forward. And that's what ketamine gives you the opportunity to do and influence in your psyche and your subconscious.
Okay. Very interesting, right? Is it facilitated? So for an example, if there's we'll stay with ketamine, but say there's someone who's getting ketamine therapy for PTSD. Hasn't really been, other talk therapy and therapists and certain medications really haven't been very effective, right? So they're going to go for ketamine therapy. What does that process look like, right? So for the individual that maybe doesn't have the capacity to, or maybe it's more challenging for them to really set intentions on their own. Mm-hmm. How does that? I'm wondering if there's a facilitator. Well, I know there's facilitators, but can you tell us how that works for somebody that has some maladaptive neural pathways that have developed?
Yes, maladaptive neural pathways is a great way to put it. So not all ketamine practices are designed equally. And so what I always recommend people to do, now it is not a core requisite or a requirement that you be in talk therapy concurrently while doing your ketamine therapy. I consider it a non-negotiable. It is my opinion. It is my belief that if you want to protect your investment, not just with your time, but your money, you want to protect your investment and get the most out of it, you will work concurrently and alongside a therapist to help you set you up for it. So for myself, my therapist is online and she's very familiar with psychedelic therapy, psychedelic health, the importance of intention and integration. So taking the insights that come up during your session, you journal it afterwards, and then you talk about it with somebody else, and you go with your therapist likely, and you get to kind of find out, how does this fold into my life? How does this apply, and how can I take this and apply it to myself going forward, kind of stuff. That is an essential part of what makes the ketamine work so well. Because again, it's a tool, ketamine assisted psychotherapy or ketamine assisted therapy. Now, are there drip clinics that you can just walk in, say, I have depression, I want to sign up for this to fix it, and they'll do it? Yeah. And a lot of times, statistically, it'll still work. But there's so much more there to explore. And when you have the guidance, so for myself, I got a little sidetracked. I would have my therapy session scheduled with, intention of what am I going to work on going into ketamine. Then I'd have my ketamine scheduled another day, so maybe the next day. And I would go in with my intentions and I'd hold them loosely because it might take me in a completely different direction than I wanted to going in. And then the day after I've had a day to rest, I'll have another conversation. I'll have another session with my therapist to integrate what came up during the ketamine.
Great. What are some precautions? Because I'm going to be here. I hear when psychedelic therapy right now is, everyone's talking about it. It's like, oh, this amazing thing. It's fantastic. But I think it's important to be well aware and educated. I've also spoken to some people that it was a horrible experience for them. And we kind of went down why that was. A lot had to do with the intentions that you were talking about, where they heard, oh, okay, psychedelic therapy is great. I'm just going to go and I'm going to do it, which is kind of why I made that somewhat ridiculous reference at the beginning of, pouring ketamine over yourself if you're having a bad day at work. But it's really important to educate yourself prior, correct? But what are the precautions for someone that's maybe listening or watching that saying, yeah, maybe it's time? What would your warnings? I'm thinking of medication, precautions, contraindications, maybe.
So contraindications will be easy because if you go to a appropriate practice, you're going to get assessed by a physician or nurse practitioner who's going to assess you physically whether or not you're a candidate for ketamine therapy. One of the common side effects is hypertension with ketamine. And so if you are having a hypertensive crisis, you're not going to be a candidate for it. They're going to make sure that gets, your hypertension gets under control before you go in, right? Active psychosis, obviously you don't want to pour gasoline on a fire that's not controlled, so you might not do that. Pregnancy is another one, another reason why you might not be a candidate. But as far as like the personal deciding whether or not, or how to go about this safely, it is to make sure that you are not going at it alone. So I'm saying this more broadly with psychedelics. So for example, I had somebody call me yesterday and they were inquiring about a certain type of psychedelic that they had gotten their hands on. And my number one feedback to them was, do not, under any circumstances, take this alone.
What was it?
Psilocybin.
Okay.
Mushroom.
Yeah. Yes, I was going to bring that
I
up.
just listened to a podcast with a very knowledgeable person on it. Everything they said, I completely concur with. They said, but using it is going to be a whole other story. It has to be set up right. And that's why when people talk about them, I've not heard, and I'm sure it exists, I'm not saying it doesn't, but typically when someone tells me, oh, I had a horrible experience with those, I'm never touching those again, I'll ask, what was the setting? I was at a party.
Yeah.
Or I was, hiding it from this person. It wasn't being taken in a medicinal intended way. And they weren't being guided by a sober friend or really a professional. It shouldn't be a friend. It should be a professional.
Yeah. And that's a thing that, and I imagine it's everywhere, but in Canada, maybe because things are less, I don't want to say loosely regulated, but I know as a paramedic and people that I know where they treat themselves, they microdose themselves with psilocybin and it does not end well. Right. And they do it that way. Like, well, I've been feeling really, really bad. This has really, really happened. So they get some mushrooms to psilocybin and they give themselves a microdose. Like, what's a microdose? They don't know. Oh, it's just a small amount. Right. And they do it over and over and over. And as it builds up in your system, then you can have a significant psychotic emergency, which sometimes happens, which
I
is
have not
a big
heard about
precaution, right?
that with cumulative microdosing. It might very well be a thing. I'm not that familiar with that. But you just said so yourself. What's a microdose? If you don't know what it is and you accidentally take like a hero's dose, like a very popular story is Paul Stamets, who's like the godfather of psilocybin. The first time he did mushrooms, he was in high school and someone gave him a bag and he ate the whole thing. He probably ingested about 10 grams, where 2 grams would have been a little bit more appropriate for his first time.
That's not
And
microdosing.
it was not, it was like the biggest macro dose you could imagine. And he's only
Yeah.
guessing it was 10 grams. He wasn't sure.
You shouldn't
but
be full. It's not meant to fulfill your
not a
appetite
meal.
if you're hungry. Yeah, it's not a meal. Yeah.
Yeah. So he ate all these mushrooms in a forest somewhere, saw God, was with God, like all these, like had a full experience, thought he was going to die, woke up the next morning to go to school, and he no longer had a stutter that he suffered from his entire life.
Yeah.
Yeah. So
But again,
but the
don't
risk
do
of a
that if you
psychotic
have a
break
stutter.
happening was very high there. And so, there's a saying with ketamine that I hope any of your paramedics and ALS providers hear, is that how you go in is how you come out. So if you give ketamine, and we're talking now, I'm shifting gears a little bit, same drug, different application, but if you give ketamine to someone that's freaking out before you can get them to a nice, controlled, safe state where they are mentally like calm-ish, usually, they've got a broken limb or something going on with them that caused them to need the ketamine. But how you go in is how you come out. And the same really applies in these medicine journeys as well. It's like you're going in with informed consent. You're going in understanding everything that, that's part of the informed consent, but understanding what might happen. And you're with people that have been there before. So you're going in with this level of safety that even when things get scary, because they can, they can get scary, they can get heavy. Some of my most profound, because I've also done ketamine therapy for myself, and some of my most profound experiences were also the heaviest, but they also led to the biggest breakthroughs for me as well.
That's where the juice is. Right? That's, you step into stuff if that's where it's, the heaviest stuff is mostly where a lot of the work has to be done. Okay, I feel like we can talk about psychedelic therapy for a whole hour, but I want to move on. But yeah, it's very interesting. One of the most popular programs that you offer is the death notification.
Mhm.
So and I know you talk about it all the time, but can you give us, for maybe people that aren't familiar with doing proper death notifications? And again, I'll put the link down to your website and the courses there. It's very affordable. I can't believe how little you charge for it.
Well, thank you.
But it's really practical information for people that are in a position, not just first responders, but anyone that's in a position of, dealing with palliative care or dealing with, family members, or anyways, let us know, give us a brief idea of what the gist is of your program.
It's really just intended to explore this part of our jobs that nobody ever taught us. It's intended to explore, how did we miss this? What do we know? What can we learn from, a lot of our insights and information have come really from hospice, end of life care community. But even then, like we don't have set standard. And I don't know what the curriculum guidelines are in Canada, but in the United States, the word death doesn't appear anywhere in the curriculum. It appears twice in the history of EMS education and like the timeline in the intro part, because it had to do with the enactment of getting first responders in the 1960s. And so it's just a really interesting thing to witness how much we've bypassed this very integral part of our jobs. And so it takes people through, it leaves them with a lot more clarity and some guidance as to how to show up for these families on their worst day, especially in systems that are doing high performance CPR, where transporting with active compressions is discouraged and sometimes not even permitted, to where termination happens more often in the field, and how to be present with the family and how to comfort them in their grief, and what does grief actually look like, and what are the things we can actually say that might be at least, supportive at the very least, if not at least very much not harmful, because there are things we can say to make it worse. But I think a lot of times what gets really uncovered is our own discomfort with death and
Mhm.
our own discomfort with this lack of familiar, like people aren't familiar with how to do it's a skill. It's a skill just like anything else, but it's a skill we've been expected to perform without any guidance whatsoever. So that's what this course acts as a foundation to do for first responders and, really anybody who gets notifications.
Yeah. So what does that do for the family? Myself, as a new paramedic, well, probably 8, 10 years into my career, very uncomfortable in those situations where I'd be okay, police are here. Great. Victim services are great. I would just leave, right? Because
Mhm.
I just wanted to get the hell out of there. So how does that affect the family? Because at the time I certainly didn't think of that.
Yeah.
Of, well, their family member died, like they're gonna have issues. But I didn't think of what what well, man, that's a weird way to say it, but what by me just leaving, I didn't think that was gonna be a big deal. But what I've learned from you is that now as the paramedic on scene there, you have an opportunity to actually make things so much better for them,
Potentially, yeah.
potentially. So what give us an example of a proper death notification, is like the words, the vocabulary, what would happen. Let's say the scenario was this: dad dies. You're walking in as a paramedic in your crew, and everyone thinks, oh, the paramedics are here, you're going to save the day. You terminate in the house and or in the ambulance, and what I would do is just leave. Right, well, assuming that somebody was with the family. But what should we do?
So it's kind of two different opportunities. So if you're getting on scene, yeah, and it's like an immediate DOA, and you have to walk back outside and let them know that you have bad news or whatever, you're just going to get to the point, and it's important to be very swift. If you can remember being very clear and using the words death and dead or died and dead, you're already going to be 10 steps ahead of most people. And you have to be clear and you have to be swift and direct with it, and you have to use the words dead and died. During a resuscitation, it's a little different. That's why it's communication. Death communication is because it's this ongoing dialogue between not just the primary provider or the immediate liaison with the family, but really the whole crew. And it gets demonstrated not just in our body language, but in our ability to be present in their discomfort, in your discomfort in their worst day. So let's say you're working up a cardiac arrest, you identify, who's the boss, right? Who's in charge of this household? Who's the one calling the shots? You're going to align and speak to them, and you're going to let them know who you are. You're going to let them know what's going on immediately and why you're staying on scene, for how long you're going to, and what's going to happen. And you're going to check in with them regularly. And maybe at this point, maybe that's a company officer, and then you have the paramedic who's maybe running it, maybe get their first round of drugs on, and then they can step away for a second and make contact with that family member as well. And so what you want to do is you want to continuously keep them informed. This is going to build trust and rapport with the family. They're more likely to accept the news if you kind of build that relationship up during the time period. And one thing to also remember is that to you, that patient was clinically dead when you got on scene, right? They're pulseless, they're apneic, you need to work them up. To the family, they're not dead until you, as the point of authority, tell them that they're dead. So you really have to treat them like they're alive in those moments. Speak about them in present day, present tense. Don't say, what were their medications? What was their medical history? No, what is your husband's medical history? Maybe use their first name if you'd like. So you want to do these check-ins at least 3. And as you're getting closer, and most medics know, like they're getting about the 15-minute mark, they're still in asystole, they were, last known well times kind of fuzzy, end title's not climbing, they are not responding to our treatments. So you might start telling them, okay, we've done X, Y, and Z. We're going to do X, Y, and Z next and see if that works. But right now it's not looking good. So you can build them up to it.
That's
You
great.
can
Yeah.
let them know, hey, this is not looking good. And then let's say miraculously you do get a pulse back. You still tell them they're still in a very serious condition. We're not out of the woods yet, but this is a good sign in the right direction. But you first responders play this small role, very tiny role, in this big journey that that patient is going to be on before they can exit the hospital, if ever.
Mhm.
And so we have to remember and keep that into consideration. And so then maybe let's say you get to the 20, 25-minute mark and you say, okay, we've tried X, Y, and Z. We're going to go for about 5 more minutes. And then we're going to have to stop. Do you want to say goodbye before we stop?
Well, that's a good one.
You might have an opportunity. It's not always going to be tactically feasible to do all these things. And so everything that I recommend and bring up and we discuss and we unpack, it's all meant to go in a toolbox and you pull it out as you see fit.
Mhm. I love that. No, that's great. Very useful for people in those positions because, like you said, it's not part of our program. I think it's starting because of the work that you're doing and it's getting acknowledged more of like, yeah, this is important. A, for the provider, and B, it can have a profound effect on the family at
Yes.
that moment because they're going to remember that moment for the rest of their lives. That's going to be a massive
It's a core memory.
core memory. And you have the opportunity to, when people have done proper death notifications, the relationship between the crew or the paramedic that gave or the person that gave that communication to that family is often life lasting, right? Like it's not, you see them at the grocery store or, in some cases you may actually even go to the funeral because the connection is there. I'm not saying that that's good or bad, but the point is that the opportunity is there to make a massive difference in somebody's life that is having a very profound core memory, like you said. And this is a topic that we could probably spend a whole episode on for the death notifications, but I got other stuff. I want to talk about some other cool things that you're doing. So yeah, for people that want more information on your death notification education, then the link will be in the bottom.
Thank you.
The CPR induced consciousness.
Hey.
This was really interesting. This is when paramedics give really great CPR or they're using devices for CPR where the patient wakes up and what do? They are clinically dead, right? They're not, the brain is, they're perfusing their brain enough so that they're starting to wake up. And so they're not biologically dead, but their heart is not working. And the only reason that blood's getting perfused is because we're just getting so damn good at doing CPR. Paramedic on scene, like, holy shit, what do you do? Do you sedate someone who's dead? Like, that's weird. Like, what's their blood pressure? I'm sure is probably going to be pretty crappy. But if it's perfusing the brain, do you do a blood pressure on somebody you're doing CPR on? That's so bizarre. It's a bizarre, weird situation that probably no paramedic working today has ever been trained on. This is what happens when you do your CPR so good as part of their normal education. So you have developed and researched it of what we do in those situations I did a post on this, did that picture, and I asked many, like, what do you do in this situation? I got a wide variety and it was all personal. Well, I would do this because of this, and I would do that. There was really no protocol.
There's no
of
guidance. No
There's
official guidance, I should say.
No. So you also have a program in that, which I'll link. And you think for what you can do or educating yourself when these types of things happen, because it's more and more often we're getting so good at it with high performance CPR and CPR devices. Give us a rundown on what best practice is in your opinion.
From what I've understood in the research, now here's the ethical dilemma that leads to moral injury and especially there have been numerous case studies where it was very clear that and they self-admitted in it that the facility or the staff didn't know about this condition. They didn't even know it could happen. So there's one of the most tragic case studies I've reviewed was a gentleman who was resuscitated for over 3 hours, 2 of which he was awake, including the intubation where they had to hold him down to intubate him. No sedation.
Yeah, because why would you sedate someone who's
because they were worried
dead, right?
If I give this person a benzodiazepine, my blood pressure is going to go down.
Dump, yeah.
If I give morphine, my blood pressure is going to go down. Fentanyl in a unstable potentially could also go down. What we now suspect, and I'm very careful about this because there are no best practices on this, it has not been established, is that some sort of medication should be given, and ideally it would be ketamine.
Right.
Because it has potentially the opposite effect. I mean, in a patient that's unstable, it may not, but at the very least, you're dissociating them. You're providing both sedation and pain relief. And that recommendation came from a Delphi study that was published a little over a year ago. If you look up Howard et al. Delphi study, CPRIC, it'll pop right up. It's an open access paper. I share it frequently. I highlight it in my course as well. And what they did, a Delphi study happens when you have an absence of best practices for a certain condition. And so instead you get literally a worldwide perspective from medical directors, clinicians, paramedics on what should we do. And they came up with ketamine as a first line, midazolam as a second line to support the ketamine if needed. But there have been some papers that suggest, and all we have is retrospective analysis of cases, but what it has suggested, it's not a proof by any means, there's still more that needs to be researched, that patients that were presenting with CPR-induced consciousness that received things like midazolam, morphine, that kind of stuff, actually took longer to achieve ROSC.
Okay.
And so so you have to do this thing where you're like, okay, well, do I compromise getting ROSC because CPRIC is suggested to be an indicator of quality? Like you're getting CPC score of 1 if they're awake and alive talking to you while they have no pulse, right? Like, your odds are high. But do you give them medication to help sedate them at the risk of resuscitating them?
Yeah. And I think the important part from what I've seen that you've done is that it relieves the ethical dilemma, right? The ethical dilemma for the practitioner that's going through this of, what do you do? And if the protocols are not in place by your service, but you have the ethical dilemma, like, I don't want to torture my patient. A genuine potential risk is that if you do give that medication, now the reason that they died was because you went off protocol and gave that medication, not because they were 110 years old and, they had heart conditions. And now it's because that you gave this medication and now you are potential of, losing your license at the least, right?
Well, and in the absence of guidance and direction, these systems and agencies are setting their providers up for moral injury.
That's what I'm saying, yeah.
Because I can't imagine, I think I named that case study Carl. I name all my case studies to humanize them. And I'm fairly certain that's Carl. I can't imagine, where is the provider that had to hold down his arms while they intubated him?
Right.
Where is the provider that had to hold his head while they intubated him? How are they doing? It breaks my heart thinking about it. But, this is something that the earliest protocol that we saw put in place was in 2016. And this was the state of Nebraska, I believe. I have so many papers in my head floating right now, but I'm nearly positive it was the state of Nebraska, and it was a statewide initiative because they had secured a grant in 2015. It was like a $6 million grant to purchase and deploy the Lucas device statewide. And when they deployed it, they kept getting reports of these patients waking up. Now, I'm not being paid for by Stryker, Lucas. I'm not, this is not proof that it's, so much better. It's just that all of a sudden the quality control of the compressions went up significantly. And as a result, they had patients waking up. And so they turned around and they created the first protocol that we had in our nation. As of maybe 2-3 years ago, there's only been like 27 protocols identified worldwide.
Are they similar protocols?
There are
ketamine?
22 different protocols.
Oh my God, really?
It was I'm pretty sure it was the Howard et al. Team that did that analysis as well. And so, and let's go back even further. The earliest case study of CPR-induced consciousness was published in 1961.
Wow.
In the Lancet.
That's good CPR.
And
manual CPR.
Yeah. So manual CPR, mechanical devices, direct cardiac massage from, cracking the chest open, all have induced consciousness in a patient witnessed and visible by the provider.
What's your prediction 5 years from now? What do you think? Do you think there's going to be a protocol? Because all these different, I didn't realize that they varied so much.
Oh yeah.
And right. But I imagine as these go through time, there's going to be some studies done, or, okay, we've had this study now for we've been doing this protocol for 2-3 years. Let's research the data, and they'll come up with a protocol that's always going to be changing, as it does in the world of VMS. But what is your prediction? Let's say 5 years from now, what do you think? Again, this is prediction. I'm not. What do you think what do you think the protocol is going to be?
I think we might be in the same boat 5 years from now. I think that's too soon.
Or at
Honestly,
least five. Oh, I guess, yeah, it could be a lot longer than that.
honestly,
The
I
boat
think
turns very
because
slow.
we don't have a proper systematic review of this topic. They tried and they concluded that there was not enough research and it was too new of a condition to warrant a systematic review. So it didn't pass the initial preliminary review required. And I have my opinions of that. That'll get too far off track of this topic. But and I think that's why maybe they opted for the Delphi study instead. And so really the Delphi study is designed to say, here's your protocol. Here's the definition of it. Here's the way it presents. Here's the protocol we recommend. And they even include like documentation and capturing data. Because if you think about it, where on your electronic PCR form is there a checkbox that says patient woke up during compressions? There isn't.
Yeah, there's not.
So while we have very little data that suggests this happens, it's supposed to happen in less than 1% of your cardiac arrest patients. When surveyed, paramedics, over 50% of them have seen it at least once, if not twice.
Yeah. That's a
So
lot.
it's likely happening more often than is able to be reported. And I suspect it's only going to happen more as high performance CPR takes more of a front seat to our protocols.
No, that's very interesting. And again, people can learn more about it through your research, and they get CE credits, correct?
They do. CAPC.
For that?
All my courses are CAPC accredited.
Yeah, which is fantastic. So if you want to learn more about death notifications and CPR induced consciousness, then they can take those programs from you.
And you'll like the artwork on both of those courses, by the way.
Oh yeah, I use that weird dance on artwork guy, right? Yeah, that guy's a bit of a weirdo.
He's a very generous weirdo with his art. In fact, I actually asked you for both of those.
Yeah, you did. Yeah, you did. So when I created that artwork, it was after a conversation I had with you. So
yeah,
no, that's really cool. All right, I'm going to do a little bit of a left turn here.
Okay, let's go.
Because this is about well-being and it's about creativity and it's about general mental health and well-being. What I want to ask you about purpose and passion. Right? This is you personally, right? So share as much as you like, but if the idea of purpose is the sense of gratification we get for doing things for others, which is very prominent in emergency services or public personnel professions, public safety personnel professions, and passion is a thing that you do that makes you feel good. So purpose is doing things for others. Passion is gratification that you get for yourself. In your career, paramedic, firefighter, up to what you're doing now as an educator and all the work that you've done, what would you say are your senses of purpose and what's your sense of passion? What gives you purpose? What gives you passion?
Well, that's interesting. Okay. So I would say my purpose feels very aligned with education, is making it's finding the stuff that is in the margins that's kind of pushed aside. Like if we were to talk resuscitation, right? We're looking at high quality compressions, minimal interruptions. We're looking at compression fraction, ROSC rates, CPC scores. This is what everybody's focused on, the survival, right? And the quality of the resuscitation, the ventilations and whatnot. What gets pushed to the side? That's the death notifications. That's the CPR induced consciousness. That's the moral injury. That's the, the stuff that lingers when the call's a little bit more relative, where you identify with that patient or that patient's family, and it leaves a little bit of a little mark on your heart. My purpose would be to create education that makes these topics that are easily avoided more approachable and even more fun to learn about.
Yeah. Because nothing's more fun than death notification and CPR induced consciousness. I
It's
totally get what you're saying. I
so
totally get it.
easy to teach from a fear-based, sensationalized state. And I never want to make these things, number one, I don't want to water them down and sugarcoat the reality of them. And I also don't want to sensationalize and fearmonger them either. Like, how do we make the education part at least fun and approachable? What my purpose has become, especially as my ability to get on an ambulance again, is no longer.
Well, you are EMS adjacent,
MEMS adjacent.
right? Which is fantastic.
It's going to be a whole new field.
I know. I love it. I use that word too. So if the purpose is educating people in this, well, you say it's fringe, but God, it's so relative, right? It's stuff that's actually more relative than a lot of the stuff that is currently taught, my opinion. And having people, as you take this course or you talk to people, as you know, you're speaking and you travel a lot, where their eyes light up. They're like, oh, this is such valuable, useful tools that I'm going to take home and actually use. And you see that, well, then, yeah, that's purpose for, you're doing things for other people, right? Now, purpose and passion are very closely aligned, right? It could be the same. So what are things that drive you, that make you feel good?
I think an easy answer would be learning. I've just stayed very curious. I mean, all this stuff is stuff that I sit there and nerd out and want to search everything on my own. Like, for example, with CPR induced consciousness, there's still a great deal of providers who don't believe that this could be real. They say, oh, they couldn't feel a pulse. What idiots. They're doing CPR on someone with,
Till the person wakes up, right? Yeah.
like, oh God.
Well, yeah.
So I came with every single reference I could find on it. Like, it's like its own literature review. I feel very proud of that. Learning and excavating and searching and discovering and finding everything I can of it. That definitely drives me passionately, which, feeds right into my purpose. But if it's just me, I would say my own spiritual, like, personal development. Anything that helps me to get curious about why I'm the way that I am, how my childhood shaped the way that I am, and what I can do to be a better person moving forward. That gives me a lot of passion.
Which brings me to the next point I want to ask you about. When we're talking about EMS adjacent and how both of us, although we're not working on the car anymore, we're still closely aligned.
Yeah.
With identity, right? With our identity. And if we think of our purpose being helping others in the first responder community, where now we can't, because you're medically retired, where you can't help people in the way that you used to help people, which is now a struggle of, okay, what's my purpose now? The passion is still there.
Yeah.
Or you still want to, you get gratification from helping people by fulfilling your passion, by fulfilling your purpose. You get passion from that. But now you've kind of lost the ability of how you used to fulfill that sense of purpose.
Yeah.
Which is a big problem for some people, for many people. So you and I now identify as EMS adjacent, which is great. But what would you say to maybe someone who is nearing retirement, and this is kind of maybe even getting into depth psychology, like we're getting into the juicy bits maybe, which could be a whole topic for a whole other podcast. But for people that are nearing their retirement or are medically retired, who now aren't able to fulfill their purpose and passion, and they're not able to, from their perspective, be who they are, what would you say to people like that? Since you've lived it yourself, like you were medically retired, and the reason I want to bring this up, it's a very significant, dangerous time for first responders. That's a high risk factor. If you research some of the work that Dr. Olivia Johnson is doing with the Blue Wall Institute, of nearing retirement is one of the ones she's identified as the fatal 10 of a potential risk factor for suicide. So as a depth psychologist and a person who has had to adjust their identity from what they were, what would you tell somebody that is either recently retired or medically retired from emergency services?
I would ask them what makes them excited,
Passion.
because that's how I finally understood what passion was. It's what excites you. Follow excitement. That's the emotion for me. And it might not be for everybody, but that's what I was invited to consider, is that passion is excitement. It's the outcome of following the things that excite you. So that answer is going to be different for everybody. And that's why I would answer that question by asking a question and say,
Exactly. Yeah.
what excites you? What were you like? And that's why I think it's also important to have some hobbies outside of work, because the number of people, I mean, I met somebody who they were they were so in love with national parks and hiking. They became a park ranger when they retired. Brilliant, right? Like, what's the thing that makes you excited? Because let's face it, a lot of people, maybe 10% of the job on an ambulance is exciting, and the rest of it's like, you know. So you can't depend on that forever. What are the other things? Maybe there's a topic in there. I also work with licensed professionals and teaching them how to essentially create, do what I've done, is how do you pivot yourself? How do you position yourself as an educator, create continuing education? And so I do that as, consulting. And the first thing I ask when they're like, well, I don't know what to create for, like, I'm an educator, I have this experience, I have this platform, but I don't know what to create first. Tell me what you love learning about. Tell me what you would learn about if you didn't have to do it. Oh, there's this and that there. That's where you're going to start.
I love it. Absolutely. So clients that I work with that are going through this exact thing, that's what I ask them. I ask them, why did you want to get into this profession in the first place? What are things that you are really interested in? And often they've never considered them. They've been a first responder for 10, 15, 20 years, and they've never really thought about doing anything else. So for you, you're following your passion of education and educating yourself. And then now you're doing that purpose while you're educating other people, and you're doing amazing things for other people. Myself, my purpose and passion is being fulfilled as a therapist. So I'm still helping my peers, and which gives me passion, because it feels great to see the aha moments in my clients. And I'm sure for you, for when you're educating people, where it's like, oh, wow, that's really, you made a difference. So I think for us, for you and me, we have transitioned to the EMS adjacent fields very successfully. So it can be done.
Yeah.
But I think you're right. Ask that question of, what are the things that you're interested in? What's your why? Why did you want to become this in the first place? And what other fields are there out there that you can still get that good sense of purpose and passion to still feel fulfilled in what you're doing? How do you stay mentally fit? What do you do?
Lots of therapy.
Do you do any creative stuff? Do you
What's
draw?
that?
Do you do any creative stuff?
Not regularly enough. I just started riding a bicycle. Like,
Okay.
I mean, I knew
What?
how
Wait a second.
to. What?
Yeah, I was just gonna say you rode a bicycle before, right? You're not just
I
learning how to
knew
ride.
how to ride a bicycle, but I've recently taken it up as a very small hobby, because I'm going to be riding a bicycle across the state of Iowa next week.
Oh, so you thought you start training now?
Yeah,
Just a week
I
before.
waited till a week before. It's okay. It's an e-bike. It's fine. It's not a
Okay,
race,
great.
and there's a lot of food along the way. It's called Ragbri, and it's this
Okay.
event that's been going on for like 52 years. And I will tell you that getting outside for play is something I have very intentionally wanted to do more of and have done nothing to get myself there. But, going out, I go out for a walk every morning. That's another thing. I just started doing this. So I wax and wane with different things. I am not a creature of habit in the ways that would really benefit me for the long run. So one of the things I've recently adopted was something called Sky Before Screen. So first thing in the morning, I go outside and I get my eyes underneath sunlight, sunshine, sky, before I let the rest of the world flood my subconscious.
Oh, that's great. I love that.
Because in that morning waking state, in that in between dream and waking state, as you're falling asleep and as you're waking up, you have access to your subconscious. And if you're falling asleep, dropping your phone on your face because you're scrolling and learning about all the horrors of the world, and you wake up first thing in the morning, and the way that you wake up, you know what they used to say about like how you needed an eye opener, like with alcohol?
Mhm.
I remember learning about that. I was like, I needed that with my phone because I hated my job so much that was the only way I could like get myself to wake up, because I wanted to just sleep through it and be depressed and not go to work. But anyways, to say that little habit, having that little boundary with myself and going outside for just some nature, listening to the birds, letting my feet touch the grass, looking around at the changes of the seasons, like that has significantly helped me. It's such a small intervention. But the biggest one has honestly been, therapy is what's helped my mental health. And then, seeking out ways to be away from a screen, and not as in a don't touch the screen. I don't look at it as that. I look at it as what can I do instead? How do I get myself outside? I want to go get in water. I want to go, there's a pickleball court downstairs I've been looking at for the last year and a half that I haven't tried out. So
once you start, you'll be hooked. Yeah. That's interesting, that state between when you first wake up, between sleep and consciousness. Salvador Dali wanted to stay in that because he wanted to create artwork in that state. So what he trained himself to stay in that state longer by sleeping with a spoon in his mouth over a bowl, so that he wouldn't let himself fall asleep, because he would fall asleep and the spoon would hit the bowl and he'd wake up, and then he'd put the spoon back in his mouth, because he wanted to stay in that state for as long as he could. And he trained himself to stay in that state for like 15 minutes. And during that state, he felt that he was most creative, which is where some of his most amazing artwork came out. By trying to stay, he recognized the importance of being in that state.
Because that's when we dream. When we dream, we are fully immersed in our subconscious.
Yeah. And if you saw his artwork, like if you're familiar with Salvador Dali's artwork, take a look at it, and you'll see, yeah, a lot of this stuff was probably created while he was in that. Very interesting, odd fellow. Great. Alex, thanks so much for being back. It's already been an hour, and I feel like we could have spent so much time on, didn't even get on about resiliency and growth and all these other things. But how can people get a hold of you?
My Instagram is where I hang out the most, but you can find me on all social media platforms at Emergency Resilience. And then my website is emergencyresilience.com. You can find my courses and good stuff, all that.
Perfect. I'll link that in the description below. So thanks so much again. It's always fun hanging out with you. When we're going to be speaking at EMS World in Indianapolis coming up in October, and you're going to be speaking at my conference. Thank you. So that's going to be really fun. Where are you going to be? Are you going to be anywhere before that?
Yes, but I don't remember. I know I'll be at the New York Vital Signs Academy with you as well. We'll see each other there.
That's right. Yeah. We're just going to be hanging out for September and October.
I think we'll see each other more times this year than we have our whole friendship put together. What a treat.
Which is super fun. Do you put on your website where you're going to be presenting and speaking?
I need to. I don't yet.
Okay.
Yeah.
All right. Well, people can find you, right? Yeah. All right. Awesome. Thanks so much. Thanks everyone for watching. And Alex, all the best to you. You're one of my favorite people. You're so incredible. Thanks so much for being on my show.
Thanks for having me.